Three,
Hello.
two, one. So you can go.
Hello.
Good evening, everyone. We are back with the episode 2 of the Soliloquy series of ISAR. And today we are having a very interesting topic. We are talking about ovarian stimulation with the focus on low ovarian reserve with Dr. Marcus Nischke from Barcelona. And to kickstart this episode 2, I would request our president, ISAR, Dr. Amit Patki, to please say a few words, and then we'll take it forward from there.
Thank you very much, and a very good evening to you all. At the onset, I must thank Dr. Ritu Hinduja, ably supported by Dr. Sheetal, who have taken the initiative for this episode. As you all know, this is our second episode of the Solid Fuel series, and this was started with an intention to have one speaker, one meeting, so that we give enough time for the speaker to talk about the topic that is passionate to him, and also to all the listeners and delegates to ask their queries and get all their queries solved. When we look at low ovarian volume and reserve, this is something which we find now in increasing in, incidence in all our practice, and I'm very thankful that we have none other than Mr. Marcus from Barcelona, who is going to speak to us on particularly on low ovarian reserve and ovarian stimulation. So I would like to thank him on behalf of ISA for taking time off on a Friday evening to be with us, and I'm sure this will help us to treat our patients better. So, all over to Dr. Sheetal and Dr. Ritu, who will now take over the program. Thank you very much, Dr. Marcus.
Thank you so much, sir. Kalyani, you want to introduce Asha ma'am, and then we can start our talk. I think Kalyani is not there. Ma'am, you want to say a few words?
I would request Dr. Asha Bakshi Madam who to kind of say a few words for this series and address our delegates, and then we can move forward with the talk.
Thank you very much, Ritu, for the invitation. And clearly, you have selected a very good topic, and that is the low ovarian reserve, and that too from the faculty from Barcelona, Dr. Marcus. And we all are really eager to listen to him, because every day in our clinic, I think one third of our patients whom we are stimulating have got low ovarian reserve. And it is such an enigma when you see a young girl of 25 years with low ovarian reserve, and you really feel it is so sad and what to do, and so frustrating getting these poor ovarian responders. So I'm sure today Dr. Marcus's talk will really throw light on many of the aspects of this problem which we all are facing in our day to day. And congratulations, Sheetal, Ritu, Kalyani, all of you for this great effort, and keep it up. Thank you very much on behalf of ISAR. Thanks.
Thank you, ma'am. Sheetal, you can take this forward.
Yeah. So can you just share Dr. Marcus's slide, please?
I don't know if I have to share.
Dr. Marcus, just 1 second. We'll introduce you, and then we can start your slides.
Okay.
Ranjit, can you share his CV, please? So thanks, Dr. Marcus, for actually doing this topic with us. So Dr. Marcus is one of the few German specialists in gynec and obstetrics with an additional qualification in gynec endocrinology and reproductive medicine in Spain. During his further training at Incel Spital in Bern in 2009 and 2010, he worked in the team of Professor Dr. Michael von Wolf, made a decisive contribution to the development of IVF natural. After several stays abroad, including Dr. Osama Kato in Tokyo and Dr. John Zhang in New York, he was primarily concerned with the question of how to use the IVF natural techniques in patients with low egg cell reserve when classic IVF stimulations no longer promise success. So as we all know, Dr. Marcus has done a lot of work in natural cycle and mild stimulation protocols. I don't want to waste too much time. Over to you, Dr. Marcus, with your slides and your presentation. Dr. Marcus, you can actually share your slides now.
Thank you, Shita. I will share the slides. Okay, can everyone see my slides?
Yes.
Okay, then I will start. Thank you very much for the invitation and for the opportunity to share my knowledge here tonight. I will start with the presentation and then I will give a lot of time for everyone to ask questions. So it's the topic is ovarian stimulation with focus on low ovarian reserve, and it is so I will give an overview about ovarian stimulation in general, and then I will really focus on low ovarian reserve. Okay, now how do I get to the next slide? Do I have to do it myself?
Marcus,
Yes,
there's
sir.
this, yes, you'll have to press it on your own. Like there's this next slide.
Somehow,
Ranjit, you've given the control to Dr. Marcus?
Yes, ma'am.
Yeah.
it doesn't work. I can't.
There'll be an arrow somewhere down, Marcus. Can you see?
Yeah, there's an
There'll be
arrow there.
Okay,
Yeah,
okay, got it,
yes.
got it.
Yes.
Okay, so I will first explain the challenge of ovarian stimulation in general. Then I will say a few words about stimulation in normal reserve patients, stimulation for IVF. Then a few words as well to PCOS stimulation for IUI and IVF. And then I will go to low ovarian reserve stimulation for IUI and IVF. And this is englobed into the focus of low ovarian reserve. Okay, so starting with ovarian stimulation in general and the challenge. So a good ovarian stimulation should obviously be safe for the patient, right? We are looking for an optimal number of good quality M2 eggs, not necessarily for a maximum number of egg. We just need quality. And then it should be ideally be low cost. It should be practical and convenient for the patient and for the medical team. It should be efficient with the best possible outcome, and then in line with the chosen treatment, either if it's IVF or IUI. And then it should adapt to the available medicine in a particular country, which can be different in different countries. I'm starting with stimulation in patients with normal reserve. These are just some pillars, some indications, which is my personal opinion, okay? Because there has been so much published and recommended, and there are so many point of views. But here's my personal point of view, how a stimulation for normal ovarian reserve patients should be. The dosage should be relatively low, 150 to 225 units, pure recombinant FSH, or a mix of HMG and FSH. According to my experience, you should never decrease the dosage during a stimulation, always go up towards the end. Because if you stimulate and the follicles grow, they are used to a certain amount of FSH that they need to develop and to grow. And if you decrease it, then you will withdraw the food for them, and they may become atresia, and the egg quality may go down. Okay? Then you should never use any GNH agonist protocols, either flare up or long. In my opinion, they are outdated because you should never use HCG for ovulation induction trigger, only agonist trigger. And in these agonist protocols like flare up and long, you need to use HCG for trigger because an agonist trigger would not work in these cases. In most of the cases, the GNH antagonist injections that we have always used can be replaced by progesterone to prevent the LH rise. We usually use medroxyprogesterone 20 milligrams per day from the start of injections up to the day of trigger. The stimulation should be in line with the chosen treatment, IVF or IUI, obviously, and adapt to the available medicine in a particular country. We are always recommending a freeze-all policy in IVF. I understand that this may increase the costs, but there is an overwhelming evidence with many studies and hundreds of thousands of cases that prove that frozen embryo transfer is superior to fresh embryo transfer in terms of results and safety. So never a fresh embryo transfer after ovarian stimulation, and you should always culture to blastocyst stage. The main reason for using frozen transfer cycle instead of a fresh cycle is that the implantation window in the stimulation cycle may be placed too early. And we know that embryos outside the body develop slower, so they may want to implant later. And then they may miss the implantation window. And this is the main reason why frozen embryo transfers are superior to fresh embryo transfers. Okay, here again, the concern of ovarian hyperstimulation syndrome and the need to prevent this. We all know it is the most dangerous complication of ovarian stimulation. It causes pain, ascites, thrombosis, and it is sometimes life-threatening. Patients need to be hospitalized. We need to treat this with plasma expanders, heparin, GNH antagonists, prolactin inhibitors. And the main cause of OHSS is the combination of HCG trigger or HCG from an early pregnancy together with stimulated ovaries. And here's the simple strategy. Avoid HCG trigger at all costs and don't do a fresh transfer. So in this case, GNH agonist protocols and flare-up protocols are obsolete. Only use GNH agonist trigger after ovarian stimulation, and use the freeze-all policy in IVF. And again, no fresh embryo transfer after an ovarian stimulation. Okay, now I'm coming to patients with PCOS with a lot of antral follicles. The main challenge in these patients, or the main cause of difficulties, is the high baseline LH level and the inverted FSH and LH ratio. In many cases, LH is double the value of FSH. And then it is very difficult to do the stimulation because the FSH levels have to be higher than the LH level in order to cause a follicular growth. On the other hand, it is very important not to stigmatize your PCOS patients as something pathologic because they are suffering from their condition and they should be explained why this exists. It is very important to understand that we are talking about a condition that is affecting the fertility. And as such, it should be eliminated by evolution since long. there must be a reason that it is still around and that many patients or many women have that. So here's the real reason why PCOS still exists. They are the saviors of humanity. What happens if a woman is starving and her fat tissue is going down below 20% of the body fat? Then her cycle stops, she becomes infertile, and there are no more children, no more fertility. And in the history of humanity, there were always extended periods of starving, of food, lack of food. And in these times, all the women became infertile, and there was no more scope, no more possibility for reproduction. And here, the women who had the PCOS came into play, because with lower fat tissue, they became super fertile. And they were the ones who had the children during these times. And this is why we are still around as a human race. So unfortunately for these women in our times, we have enough or even too much food. And this is why they are suffering, okay? But we have to tell them that because of them, humanity is still around, that they are the saviors of humanity. And here comes the role of weight loss and metformin co-treatment. Because if they lose weight, especially the type of PCOS who has overweight, then the cycles become normal again. And metformin is very, very important for all of them because they simulate metabolism, which is similar to weight loss. Okay, so metformin is proven to be a very important treatment. Now, if you want to achieve follicular growth in patients with PCOS, it is the letrozole is the best possible medicine. I have worked in India in 2015-16, I believe, and at that time letrozole was prohibited and could not be used. But I think that it has been reversed, that now letrozole is available for treatment again in India. And letrozole treatment in PCOS patients can be used for stimulation of 1 or 2 follicles, for IUI, or for IVF stimulations. If you want to stimulate for IVF, you give 5 milligrams of letrozole for 5 days, and this together with 150 units of FSH, and then you stimulate, and then you will get a good response. If you want to stimulate for IUI using letrozole, you give the patient 5 milligrams of letrozole during 5 days. Then you wait for 3 more days and you do an ultrasound. If you see a dominant follicle has been recruited, you just follow this, trigger it, and program the IUI. If you see that after these 5 days of letrozole and 3 days of waiting, nothing has happened, then you start to stimulate her with 150 units of FSH, and then despite the high amount of medicine, you will only get 1 or 2 recruited dominant follicles, because the letrozole pre-treatment has already selected the 2 follicles that will later grow with the stimulation, and you are safe. As you know, the main problem of the stimulation is the high baseline LH level. And if you treat this with progesterone, the LH may go down and you will get a better response if you stimulate. If progesterone treatment like medroxyprogesterone, 20 or 30 milligrams per day, is not enough to bring the LH levels down, then you may need to use GnH antagonists to really bring the LH down, and then you do a stimulation. But here again, very, very careful. Ovarian stimulation should be done only with recombinant FSH, not with HMG, because HMG contains LH, and this is exactly what we don't need in patients with PCOS. And here again, because especially in this patient pool, we have the importance of OHSS prevention during ovarian stimulation. So in PCOS patients, a long agonist or flare-up protocol using HCG as trigger is obsolete. And now, finally, I'm coming to the low ovarian reserve. So we have 4 clinical stages, which I will introduce later. Okay, so there's a so-called compensated stage, a stage of desynchronized cycle, a stage of pathologic premature LH rise, and the stage of blocked follicle growth. And there's a simple treatment approach in each stage. And now I will explain how it works. So first of all, we need to diagnose the low ovarian reserve somehow. And this is usually be done with biochemical markers. For example, the anti-Müllerian hormone, the AMH, which is secreted directly by the antral follicles. So we can test it anytime in the cycle. We have little variability during each cycle and between 2 cycles. It really gives us a global overview about the actual situation of the ovarian reserve. But then we can also use a combination of FSH and estradiol during the first 5 days of the follicular phase. And here we may have a high variability between 2 cycles. We can see one cycle is completely normal, and in the next cycle, it is already different. And this is giving us a good estimation of the quality of each cycle. And an indication if we should stimulate in this cycle and use it or not. Then we can look at the LH and the estradiol at the moment of ovulation. And this will give us an idea about the quality of the ovulation. And then finally, we can look at progesterone and estradiol in the luteal phase. And this will give us an idea about the quality of the corpus luteum, and if we have a corpus luteum insufficiency. Then we have the means of ultrasound and to count the antral follicles. This is quite experience depending. So there's a learning curve, and the doctor who's doing the examination should be trained. But it can be a low-cost alternative to biochemical markers, because you just see the ovarian reserve in front of you. And you can evaluate, it allows a good evaluation of the ovarian reserve. And in some cases, it may be necessary to ask the patient to come several times into your office and to do several ultrasounds during the cycle and to observe the follicle growth during the cycle. It is important to detect ovulation disorders and pathologic cycles. Okay, here are again the 4 stages. The compensated stage, the stage of desynchronized cycle, stage of pathologic premature LH surge, and the stage of suppressed follicle growth. And now I'm going into one in detail. So the first one, the compensated stage, has a pattern like this. You see low AMH levels, usually less than 1 microgram per liters. You see a relatively high FSH during the early follicular phase, something between 10 and 20 units, and normal E2 in the early follicular phase. But, and this is important, you still develop, or the patient still develops a mature follicle of more than 18 millimeter spontaneously and has a long cycle equal or more than 26 days. So we can see here that the ovarian reserve is reduced, but the endocrine compensation mechanisms are still working and in place. And then often you hear from a patient, oh, I had this accident, and then my cycle became shorter or irregular. Or they say, yes, someone in the family died, and then the cycle became irregular. And then they say, yes, this event did this, or this accident did this. I broke my leg and suddenly my cycle became irregular. No, it was already compensated low. And then suddenly the emotional or physical stress of the accident or the trauma of the person who died in the family caused that disruption, stopped the compensation. And then it started to shift to the next level, the stage of desynchronized cycle, for example. So what do we have here? We have low AMH levels, indicating the low ovarian reserve, but we have normal FSH level in the early follicular phase. And if you only look at the FSH levels at the beginning of the cycle, you may miss the low reserve, because you always have to look at FSH and estradiol together, because here we have high E2 levels in the early follicular phase. In this kind of pattern, we can see a development of a mature follicle, which becomes more than 18 millimeters, but the cycles lengths are reduced. So what is happening here? We have a pathologic follicle formation during the luteal phase, which should not happen normally, due of a higher basal FSH level. And then when we see the patient at the beginning of the cycle and we do an ultrasound, we see, oh, she already has a dominant follicle present. We say, oh, she has a cyst, but this is not a cyst. This is a dominant follicle which has formed during the luteal phase already. And then obviously this dominant follicle will ovulate earlier, maybe even on day 7 or 8 of the cycle. And then you have a shorter follicular phase and a desynchronization of the follicle growth and the endometrial maturation. In the stage of pathologic premature LH rise, you have the following pattern. At the beginning of the cycle, you still see the low AMH. You see again high FSH levels in the early follicular phase and normal E2 levels. But here we have the so-called pathologic premature LH rise, and cycle length is less than 26 days. So what happens here? We have a lack of a specific inhibition of LH during the follicular maturation. And the LH surge and the ovulation occur before the final maturation of the follicle development. So with small follicles, less than 17 millimeters, and with low E2 levels. And the eggs that ovulate from these small follicles are from poor quality, and the embryos too. And then the corpus luteum, which develops from such small follicles, becomes weak, and we have the so-called corpus luteum insufficiency. Now I'm going to the 4th level, which is the last stage before the actual menopause. So we have very low AMH levels and very high FSH and LH levels, low E2 levels, and we have a suppressed follicular growth and long and irregular cycles. So clinically, we see these cycles, and if the patient comes like this, then we should already be very aware. High FSH and LH suppresses the follicular growth by downregulation of their respective receptors on the follicle. So basically, all these high FSH and LH levels, they make that the receptors on the follicles go down. And from time to time, the ovarian reserve recovers, and a follicle may grow again, ovulate, and then you have a cycle again, or a bleeding again. So this makes long and irregular cycles. So what are the different stages having an impact on fertility? So if in the compensated stage, where we have a low reserve, but we still have good, long, and regular cycles, we probably don't have a direct impact on female fertility, except if there are other reasons, like blocked tubes or sperm factor, or endometriosis or whatever, but not the actual problem of the cycle. And these are the typical low responders in ovarian stimulation. If you want to stimulate them, then we only have very few follicles that occur. And then in the second stage, obviously, there are implantation disorders because the ovulation occurs too early. And imagine the patient has just stopped bleeding of her menstruation, and then the ovulation already happens. Then the lining is thin and not ready for implantation. So here lies the problem of this stage. And then we have the stage of pathologic premature LH rise. Here we have a poor egg and embryo quality if the ovulation occurs from these immature follicles. So this is the reason why they don't develop. And of course, the luteal phase defect, because in this case, we don't have enough progesterone. And in the stage of suppressed follicle growth, we have long periods without ovulation. Without ovulation, obviously there are no eggs, and there can't be a pregnancy. And then if there's an ovulation and if there's an egg, we have all the other reasons of the other stages together. We may have dysynchronization between the endometrium and the eggs, and we have poor quality eggs. So these patients usually don't get pregnant naturally. So what can we do in each stage? Now I'm talking about possibilities that everyone can do in their consultations. I'm not talking about stimulation for IVF. I'm talking about stimulation or treatment for IUI or timed intercourse that everyone can do at home. Okay? So in the compensated stage, there's no need for any special treatment if there are no other reasons for infertility. Obviously, if there's blocked tubes or if there's a sperm reason, you can do a very mild stimulation or use a natural cycle, IVF in this case, right? But otherwise, there's no real treatment if you detect this by chance. Now, in the stage of desynchronized cycle, you can try to resynchronize the cycle again with combined oral contraceptive pills, which you start in the luteal phase. I will explain how this works later. And then in the stage of pathologic premature LH rise, what we need to do is to inhibit the premature rise somehow. This can be done either with tamoxifen or with clomiphene. I will also explain how this works. And in the stage of suppressed follicle growth, FSH and LH suppression with ethinyl estradiol. Okay, now in the stage of desynchronous cycle, because this is the first one we have to treat, what do we have? We know that high serum FSH levels during the luteal phase. What is the luteal phase? The luteal phase, in the luteal phase, we have the corpus luteum, we have progesterone and estradiol, which act like pills. And during this, we have low FSH levels. But with advanced low ovarian reserve, these serum FSH levels are rising due to the lower serum inhibin concentrations. And this was described by Robertson in 1985. Because the ovarian reserve, the antral follicles, they secrete the inhibins, inhibin A, inhibin B, which are stabilizing the hypothalamus and the hypophysis. Without this inhibin from the ovary, the hormones produced by the corpus luteum are not enough to suppress FSH sufficiently. And the result is that pathologic follicle formation during the luteal phase, in a shorter follicular phase. in the following cycle. And the treatment is you give combined oral contraceptive pills for 10 days during the luteal phase. For example, you start from day 16 to 26 after you have confirmed the ovulation. And this can prevent the pathologic follicle formation and help to resynchronize the cycle again. So at the end, when you do this, you give these contraceptive pills during the luteal phase, your period will come when you stop it, and then there is no dominant follicle. But it can either switch to the compensated stage, so then you have cured it, or it switches to the stage of pathologic premature elytrise. And here we have the following situation. So we have we can use the anti-estrogenic effect. It is a competitive inhibitor of estradiol at the receptor. So the anti-estrogenic effect of tamoxifen or clomifen, but we prefer tamoxifen because clomifen makes a bad endometrium. It can be used to delay LH surge or block it completely. This has been described by Lindenberg in 2013. In women, the LH surge usually is triggered by high serum estradiol levels, which activate the E2 receptors at the hypothalamus. And as a competitive inhibitor of these E2 receptors, tamoxifen is able to block them if it is given before reaching the critical serum estradiol concentration. So you should give it at least from day 7 or even earlier. And in patients with the reduced ovarian reserve in this stage, normal follicle maturation can be achieved using tamoxifen. If in your country it is not possible to use tamoxifen because it's an off-label use, obviously, then you can use clomifen. You will get a bad endometrium, but still you can achieve a good ovulation. And in the case where you have a very young patient in her early or mid-20s, and she has already a last stage low ovarian reserve, then with FSH levels more than 30, so these high FSH levels can block the follicle growth by downregulation of the FSH receptors on the follicle. And here you can use ethinyl estradiol to bring FSH down to normal levels and enable the follicle growth again. This was described by Czech et al. In the 90s. But here again, this treatment will not work with patients in their late 30s who have a low reserve. This only works with very young patients who still have a good egg quality. So, and the ethinyl estradiol treatment can only be successful if you can see at last one antral follicle there. And you have some estradiol. If there's nothing at all and the ovaries are empty, obviously you can't do anything. But if you have that one small antral follicle and you give the ethinyl estradiol, you will be very surprised that only after a few days of treatment, you will get a follicle growth, even if the patient had a long amenorrhea before that. Here, I have assembled a model treatment for such a case. So this is combining the oral contraceptive pills, the ethinyl estradiol, the tamoxifen, and an ovulation induction with GnRH agonists. So you give the patient the oral contraceptive pills for 10 days, could be longer also, 10, 15, 20 days, as long as you want. Of course, if the patient is cycling. Otherwise, you can start this anytime during the amenorrhea. You do a hormonal assay FSH E2 on day 2 or anytime if there's an amenorrhea. And if the FSH levels are higher than 25 and you have some estradiol, then you give ethinyl estradiol 25 micrograms or even 50, whatever you have available, per day until the ovulation induction. If FSH is less than 25, there's no need for ethinyl estradiol. You give 40 milligrams of tamoxifen, or in case of clomiphene, you give 50 milligrams of clomiphene from day 7 until ovulation induction. Sometimes you can even start earlier. You do a hormonal assay on day 10, you look at E2 and LH, or you do an ultrasound. If you see that E2 levels are high, are low on day 10, then you repeat it 1 or 2 days later. Otherwise, you can already trigger with the injection of decapeptyl or whatever triptorelin or agonist. You can, in this case, you can also use HCG because you are not threatened by any OHSS. But we try to avoid it anyhow. And then you can use timed intercourse or IUI on the following evening, or you do an egg retrieval in a natural cycle 36 hours later. And in the case of IVF, you can do a fresh embryo transfer. And we usually give vaginal progesterone support. Okay, now this is the conclusion and the summary. There are 4 different stages of reduced ovarian reserve. The cycle disorders of stages 2 to 4 may have a negative impact on female infertility, and I have explained how this works. It is possible to treat these cycle disorders with a simple medical treatment. And then we always need randomized controlled studies to confirm the efficiency of these treatment approaches. And unfortunately, there are very few organized associations and groups that are looking at these patients. Although everyone has them in some clinics or consultations, it's more than half of all the infertility patients with a low reserve. But still, no one has classified the patterns. No one has looked at any real workable solutions for them. And this is my approach. Okay, thank you very much for listening. This is my email address. If anyone has specific questions, can always contact me. And now I think we have some time left for questions.
Okay. So thanks, Marcus, for an amazing session and a wonderful talk and an entirely different approach on poor ovarian responders, because we were generally following the Poseidon criteria and we were just treating that. So this is an entirely different approach for poor responders. So I think you spoke about this tamoxifen protocol. So do you follow this protocol for most of your patients, or you prefer clomiphene citrate with gonadotropins for your patients? So what is your preferred protocol?
So the thing is this, tamoxifen works better because tamoxifen is having a great effect on the endometrium, right? So here, clinically, you get a better result. The problem is that it is obviously off-label use. And in some countries, and in most of the countries, doctors are afraid to use something that is completely not related with infertility. It is a cancer treatment, right? So in most of the European countries, and also in Spain, in these kind of patients, we use clomiphene, although we know that the endometrium is affected. But at least we have some tools to treat these patients, right? And the most important problem is to treat this premature LH rise. You have the patients coming into your consultation. You see her on day 2 or 3 of cycle. She has 1 or 2 small follicles. You see her 5 or 6 days later, you see a dominant follicle of 13, 14 is growing, you are happy. You see her 3 days later, the follicle is gone, already ovulated.
Yes. We see a lot of that in poor responders, actually.
So,
Yeah.
so this is exactly that situation. And here you give her either tamoxifen, ideally, 40 milligrams is ideally already from the start of her cycle, latest 6-7 days, 6-7 of cycle, because you have to start this before the ovulation happens, or 50 milligrams of clomiphene. And clomiphene, you don't start, and the idea of clomiphene is not that you stimulate, no. The idea of clomiphene is that you inhibit. And then you will be surprised that the follicle will still be there after day 10, and you can still use it. It's a really efficient.
So, Marcus, my question here is that if you're not attempting a fresh embryo transfer, and if you're going to retrieve the follicle, the egg oocyte from the follicle, then I mean, using clomiphene, even if it has a negative effect on the endometrium, should be fair enough, because we're not going to use that cycle.
No, don't confuse. I was talking about IUI or timed intercourse.
Okay. Yeah.
Because most of the doctors will have this only. Only a few of you will have a clinic and IVF at hand. If you have a patient like this with a very low reserve at hand, and you are able to do IVF, then as you say, we have to freeze all, and you have to use either antagonists and to stimulate, or the progesterone, because this works fine as well, and even better than tamoxifen, right? To prevent the LH surge. But here I was talking about the majority of the cases, which is just timed intercourse and IUI.
Understood.
Also,
where you have to finish the fresh cycle.
Yeah.
Right?
So Marcus, when you do these cycles, if you're planning to do an IVF cycle and you plan to pool, if you're doing only tamoxifen cycles, so can you do back-to-back cycles, or do you need breaks in between? So whenever we do stimulated cycles, we need a break, right? Like even if it's a mild stimulation.
No, in these cases where you can only get 1 or 2 eggs, you can do back-to-back. There's no need for waiting.
Okay.
You can restart with the next period.
Okay. Dr. Marcus, for everyone's knowledge, can you just explain what are the mild stimulation protocols? So can you just explain the protocol a little bit to the audience, because they will be very happy if you can just describe the protocol a little bit with injections, with mild stimulation.
Okay, so let's say we have a patient which has a low reserve, right?
Yes.
And we want to use a mild stimulation for IVF, right? So here is what I would do. At the beginning of her cycle, I would see her. I would test the FSH, the estradiol, the LH. I would do an ultrasound and see how the situation is. The higher FSH is, the lower I would stimulate, right? So if the FSH is below 15, I can still stimulate with 150 units. If it's higher than 15, we can only give 75 or even 50, because then we will not get anything more, right? Then I would give medroxyprogesterone pills, 10 milligrams 3 times per day, and do the stimulation. And then after 7 or 8 days, I would see her again. And if you see that there is a growing follicle around 14-15 millimeters, there you start giving an antagonist. So the role of antagonists is important in low reserve patients. In normal reserve patients or in good reserve patients, I would never use antagonists, because here only with medroxyprogesterone, it is very unlikely that they will ovulate. But if you have a low ovarian reserve patient, at a certain stage, like 15 millimeter follicles, you need to introduce antagonists.
Along with medroxyprogesterone?
The moment you introduce the antagonists, you stop medroxyprogesterone. It's not needed anymore.
Okay.
Okay?
Yeah.
And in these cases, you will never get more than 3-4 follicles anyhow.
Okay, so you start the injections as in gonadotropins right from the beginning in mild stimulation, or you started from the 5th day, or?
No, right from the beginning.
Okay.
Right from the beginning. Because this is a completely different situation than if you want to do a mild stimulation with a normal responder.
Okay.
Because this would be because you want to save medicine or you want to do it more natural. Like, this is a choice, but in a poor responder, this is not a choice. You cannot stimulate a poor responder with huge amounts of medicine. You will block everything. So the lower the reserve is, the more gentle you have to stimulate. And in most of the cases, I just give them 75 units of FSH with the idea to have 2 or 3 follicles. It's usually in these low responders, you have to stimulate like if it is for an IUI.
Okay.
And then you can still get good quality eggs. But if you give them too much, you will burn everything.
One question I wanted to ask Marcus was, you said you give ethinyl estradiol for patients who have got high FSH. So instead of ethinyl estradiol, is it okay to give estradiol valerate, or you would only
So
like
here's the problem. There are 2 problems. We tried this, of course, first because it's easier to get and easier to find. But problem number 1 is, for some reason, the ethinyl estradiol will not trigger the premature LH surge.
Okay.
But if you give normal estradiol, like estradiol valerate, and you will get your FSH and LH down at the beginning, you will maybe able to initiate the growth of the follicle, but then suddenly you will lose the follicle again because the LH rise comes. And with ethinyl estradiol, this seems not to happen. This is number 1. And number 2 is, if you measure the estradiol inside during the stimulation, you can be sure that if you give ethinyl estradiol, that all the estradiol that you see is coming from the follicle.
From the follicle.
Because it's not measured. The ethinyl estradiol is not measured if you measure estradiol. But if you give estradiol valerate, you will measure the combination of your follicle and the amount of medicine that you give. So it's useless. You don't know if your follicle is growing or not.
So how do you get ethinyl estradiol? Because I'm just wondering, I know it is available in the oral contraceptive pill, but do you get a special formulation for that?
So in some countries, it can be commercially purchased, or any pharmacist is able to make it themselves. So they can mix it in the pharmacy, and it's in the form of powder, and they put it into capsules. And then they sell you the capsules. So it is custom made. At least in most of pharmacies in Europe and in the United States. I don't know about India.
I don't think
No,
so.
we won't get it. No.
No? Okay.
That
I
will
mean,
be difficult.
you can ask and try. You may be surprised.
Yeah.
Okay, there's a question from some Dr. Radha Nirmal Marcus. She's asked a question for a 23-year-old female primary infertility with an AMH of 8 and FSH of 43. So what will be your protocol for her ovulation induction?
So 23 years old, AMH 8. So she's very young, right?
FSH is 43.
Okay, so here this would be a perfect candidate for the ethinyl estradiol, right? If we just want if we want to induce the follicle growth, sometimes, so the problem here is if you don't have ethinyl estradiol, there's only the only thing you have left is, for example, oral contraceptive pill with this combined ethinyl estradiol with some progesterone.
Just, yeah.
So what you have to try, but obviously in this case, you have to do the egg retrieval. You have to trigger and you have to do the egg retrieval and you have to freeze the eggs because you can't do a fresh transfer, right? So you can try with medroxyprogesterone and this will bring the FSH down, right?
So simple medroxyprogesterone, no ethinyl estradiol.
First thing is you can try with normal estradiol. You give like, let's say 8 milligrams of normal estradiol. Valerate. Together with tamoxifen. Okay, because you need to prevent the premature LH rise. So what you do is you start with 8 milligrams, 6 to 8 milligrams valerate per day. Then you, after 3 days, you do a scan and an blood test. The FSH is going down. You see your follicle starts to grow. At this moment, you introduce tamoxifen 40 milligrams. And then you bring that follicle up to, let's say, 14 millimeters. At this moment, you start an antagonist and you have to stimulate with 75 FSH or HMG until the follicle grows to 16, 17 millimeters, and then you trigger. Then you may be able to have timed intercourse or an IUI. Okay.
One more question I wanted to ask, and it is not on low ovarian reserve, but it is on PCOS. A patient has got high LH, basal high LH every time 16, whether you give her oral contraceptive pill and then do basal LH, and it is always coming around 16, 17. So what can we do in such a case when basal level is very high, LH level?
So if you want to do a timed intercourse or IUI.
No, I want to do IVF for this patient. I want to stimulate her. Yeah.
So in this case, you use letrozole. You can already use this in India or not anymore.
We can.
Okay, so you give her 5 milligrams of letrozole for 5 days, together with 150 units of FSH. And then you stimulate, and then you give 20 milligrams of medroxyprogesterone as well. And the combination of this should be enough to induce a good ovarian response.
Okay. So on the same day, you start 20 milligram of medroxyprogesterone, you start 5 milligram of letrozole, and you start 150 units of FSH.
Yes, correct. All three you start together at the same day.
Very good. Thank you.
Okay, Dr. Marcus, a lot of questions related to use of these like DHEA and testosterone gel. So what is your opinion about these products? Like, can we use these? What do you prefer?
So testosterone gel is very dangerous. It is really dangerous because it can permanently damage or influence the patient, and then the damage that you said is not reversible. So never use testosterone gel in female patients. DHEA is something you can try, like 50 or 75 micrograms, I think.
Yes.
Yeah.
The problem is that if it works, it works very short. Means it works not more than 2-3 months.
Okay.
So you don't want to treat your patient for 3, 4, or 6 months and then start a treatment. When you plan your treatment, like that patient that was presented here, the 23-year-old female with FSH 43, you may give her DHEA and then you start the treatment cycle right away, because this can make the situation better, but only for a short time.
Okay.
This is like a bonus that you have.
Okay. Testosterone gel, you said, Dr. Marcus, is not good, but then even for shorter durations, like 3 weeks, it's going to be harmful?
Yes, because what does it do? It has a very similar effect on the ovary like letrozole. Because what is letrozole doing? Letrozole is an aromatase inhibitor. That means that it will inhibit the conversion of testosterone to estradiol.
Yes.
You will increase inside your ovary, inside the follicles, you will increase the testosterone level.
Yes.
And you will see very low estradiol levels. So this will bring your LH down first, which is what we want, right? And we will also increase the FSH receptors on the follicle caused by the testosterone. So if you give testosterone from outside, you will have the same effects, but you will have a systemic effect of the testosterone everywhere on the body, not only on the ovaries. And the little that reaches the ovaries is not enough to do anything, right? So it is much more efficient and much more targeted to use the letrozole than the testosterone gel, and you don't have any of these side effects.
Okay.
So I would not use testosterone gel in any case in female patients.
Okay. There's a question from Dr. Monica. She's asked that is it advisable to do an IUI with an AMH of 1 or lesser in Poseidon 3 or 4? So what is your take on that? So
basically a very low ovarian reserve, right?
Yes.
And she wants to know if we can still do an IUI.
Yes.
Of course, as long as you can get a healthy follicle of at least 16, 17 millimeters, somehow, you can always try this. Because an IUI or timed intercourse is better and works better for patients than IVF in low reserve. Because if there are no other conditions like low sperm or a blocked tube. But if the low reserve is the only reason why it does not work, better use IUI or timed intercourse, because the conditions inside the body are always better than after an IVF. In the IVF, when you take the eggs out, they have a thermic shock, right? Then they are exposed to temperature and pH fluctuations. They are manipulated. They are in some mediums that they don't like. So all these factors make that the eggs and the embryos are not optimal. But inside the body, it's still good, right? So in these last hope or no hope patients, IVF is not giving an advantage.
I have 2 last questions, Dr. Marcus. One, I want your opinion on ovarian PRP for ovarian rejuvenation.
Okay, so here's my opinion, and we have discussed this among other I mean, we had a meeting with several university professors in Germany, and at this point of time, there's no real evidence that this is doing something, and there's no real explanation how it should possibly work, right? Because the only thing that you do is you set an irritation, right? You're injecting something into the ovaries that is triggering some kind of inflammation or some response to the from the body, and this short-lived response is the only thing we have, and this is the only likely explanation that something is happening there locally.
Okay. So if you do the ovarian PRP, how long do you wait before the next stimulation or next, like anything? Like if you're doing an IUI or you're doing an IVF, do you wait for a period of 1.5 months, or you start immediately?
So first of all, I personally don't recommend that at all.
Okay.
I know that many patients are asking for this, and then you can't refuse, right?
Yes.
So in this case, I explain my opinion, but if they still insist, I will still do it. And in this case, it makes sense to start whatever you do right away, because you will take advantage of whatever you put there immediately. People think that there may be some embryonic stem cells and they grow and they do something, but I don't think this is possible. So,
even with stem cells?
Sorry?
Even so, ovarian PRP or stem cells? So you don't prefer either?
No, because it is the same idea, no? It is the same idea that you put either plasma or stem cells or whatever, and then they are supposed to do something there.
Marcus, you've said a lot of like you've debunked a lot of things in this webinar.
Yeah, I mean, this is our in our group of specialists and scientists. This is our opinion, right? We are just looking at the available literature. We are looking at the what can or would possibly really happen inside. What is the physiology and what is the things that can happen here? And we try to find explanation behind it.
And yes, you've done so much of research also, so I'm sure that you all are really working a lot on this topic.
Yeah, we really did, and we until now, I mean, it's still early, but until now we can't really see benefit. But if we are proven wrong, then we are wrong, right? And I understand that this is a hype now, and patients who are desperate, they are looking for something. And if this is there something, then this may even work, because we still have the placebo effect, and the placebo effect is something we should not underestimate, right? The placebo effect always has some effect. And if it's only the placebo effect...
Marcus, listening to you, it seems you do like IUI. People say that if AMH is less, antral follicles are less, you should go for fast-track treatment, and that is IVF. So what is your view? Because everybody is rushing towards IVF for patients with low ovarian reserve. So what is your feeling about it? Does IUI still have a place, or no, we should go for IVF?
Yes. IUI has definitely a place, definitely, because it's low cost. Because we have... Now I gave you some tools that everyone can use in their consultations. Easy treatments with tamoxifen or clomifen or estradiol, and it works in many cases. Because if the reason for the infertility was the low ovarian reserve, then you can treat it. And then there's no need for going to IVF, but if you don't get to that nice dominant follicle, if the only way is to use antagonists, to use a stimulation, then it may be only through IVF, right? It depends.
So,
but the younger the patient, the more IVF makes still sense.
Okay.
In older patients, IVF is, if you have a very low reserve and patients over 40, then forget IVF. It will never work.
okay.
Dr. Marcus,
So,
I have one question which Dr. Shivani Jain has asked. What is the size of follicle trigger? As in, is it different when you are doing a normoresponder, as in you trigger at 19-20, and when it's a low responder, do you trigger a little earlier, as in, is it 16-17?
Exactly. And this is key. This is key here. In patients who are low responders, in patients with a low ovarian reserve, you need to trigger with follicles around 16, 17, maximum 18. You don't want to let them become 20 because then they are overripe. This is also in contrary of all that we have learned. Because in normal responders, it is better to wait until they are 20, 21. But in these low responders, you should trigger earlier. Okay?
Yeah.
I just have one last question before we wrap up. There are these protocols where they use low dose of HCG along with gonadotropins from the second day onwards in women with low ovarian reserve. What's your take on it?
So they are using HCG, right?
Yes, low dose, around 150 to 200 IU.
So I don't see any sense. So what HCG is what is HCG doing in this situation? It will probably bring your FSH down, right?
Yeah, for the
So-
LH activity,
Let's
that's the concept behind, yes.
So
That the LH from the HCG is superior to the LH from the HMG, and that's why they kind of use recombinant FSH along with a very minute
So-
dose of HCG.
So we have the problem in these patients that FSH and LH is too high, right? And that this is blocking the ovarian growth, the follicle growth. And anything that brings LH and FSH down at this point is probably useful to initiate a follicle growth. And it is possible that HCG at this stage is doing something in this direction. But I have to say that I have no experience with HCG during a stimulation. So I can't really say something because I have no personal experience with this.
Okay. Dr. Marcus, what is the role of dual trigger in poor responders? Do you prefer a dual trigger or do you prefer only giving an agonist trigger in all your poor responders also?
So dual trigger means a combination of HCG
And
and
agonist.
agonists, right?
Yes.
So in these cases, you can trigger with anything. You trigger whatever is available, whatever you like. I don't recommend, and I'm strictly against HCG in a stimulated cycle, especially with a good response. But in low responders, where you always have maximum 3 follicles, you can use anything that you like and whatever is available or cheapest or most convenient. There's no advantage in either or dual or HCG or whatever you get, whatever you have at hand is working.
Okay, thank you, Dr. Marcus. I think this was a very, very interesting session. I personally enjoyed it a lot, and a lot of controversial topics were debunked and answered. And I personally have a very strong take-home message from this talk, and I'm sure our audiences also have some very clear take-home messages. It was very interesting to see how you had categorized low ovarian reserve, and this is the first time I got to hear of something like this. And I'm going to go back and listen to this talk all over again to understand it much better and much deeper. I need to thank Sheetal for recommending you and making sure that you come on this platform, because Soliloquy series is something that it's very close to my heart. So I wanted it to be really nice, and she's helped me realize this dream. I thank Dr. Asha Bakshi and Dr. Amit Patki for their presence, and I thank Onference for providing us this platform to do this amazing program. And I also thank our academic partners, Mayor, for enabling us to be able to do this program and make it reach to around 1,000 plus audience that had registered for this program. So thank you everyone for joining in, and thank you for making this program a big success. Good night, and we'll see you again for episode 3 on the second Friday of the next month. Thank you.
Thank you so much,
Thank you so
everyone.
much.
Right. Bye, Marcus. Thank you, everyone.
Bye.
Ranjit, we can go offline.
Thanks, Marcus. I